everybody. Welcome to the Monday Afternoon Journal Club. Ed Bauter and Dan Schwester here. How are we doing, Danny?
I'm doing good. How you doing, Ed?
Not too bad, man. We're going to talk about some exciting stuff today. We have a study coming out of Israel today. And well, this study this is from Ritblat et al., and they looked at complications arising from pre-hospital tourniquet application. So what's interesting in this study, and this is coming out of academic emergency medicine, this study looked at complications after the application or after a patient was received at the hospital from having a tourniquet applied. The methodology is really interesting here because it is a small number of patients. I think it's 84, but really what they wanted to look at was the contamination of the injury on scene. How is that affected later on in patients that receive tourniquets for whatever hemorrhagic injury they get? So it's a very, very specific look at what actually happens in hemorrhagic injury, but they found some interesting stuff here.
Yeah, I think they did. I don't know what the application would be for us. It was, again, there's a couple things in it. It was a small study. I believe 128 candidates were identified retrospectively as having tourniquets applied. Some of those got taken out for a variety of reasons, like they were under 18. There was other factors. So they ended up having about 84 patients identified in the study, which to me, for retrospective, is not a huge thing. But then again, we don't see a lot of tourniquet applications outside of tactical events or mass casualties or things like that. And thankfully, they're still rare for the most part. So That's a good thing. When you look at the outcomes or what they were looking at, what kind of got it to me was, a lot of the things they looked at, like one of them is gross contamination or infection, where most of the wounds were contaminated. So these people still have to go up for a washout. They still have to get cleaned up. They're going to get on antibiotics, and there may be some residual infection or something that doesn't respond to the broad spectrum stuff. I don't know if you can blame the tourniquet application for that. I know they included it here. There were a couple instances of compartment syndrome, which people tend to look at and say that's a tourniquet issue. But severe blunt trauma or high energy trauma to an extremity can cause compartment syndrome just from the injury itself. Again, didn't really go into whether the tourniquet caused that or whether this was just a complication that couldn't be avoided. However, it's interesting. It's interesting because we've kind of grown up with this idea over the last few years that tourniquets are completely safe. Tourniquets can be used anytime. If you're not sure, put a tourniquet on because nothing bad is going to happen to the patient. And just like everything we're finding in medicine, that's not true. There's always side effects. There's always complications from things. And again, instead of reflexively putting things on, maybe the best thing this study's teaching us is, hey, let's sit back and actually look and see if this is warranted. And if they have a tourniquet applied, is the bleeding stopped? Can we get that off as soon as possible? And can we move them to the next level of care? That's probably where we're going to go with this. It's not just empirically doing things in medicine tend not to work well.
Yeah, and I think that's right. And here, like when we're actually looking at the paper, one of the things I really like about this is they showed a diagram of where tourniquets were most commonly applied. And so, I mean, I don't think it's very surprising to see it's typically upper extremity injuries, right? And here you got lower extremity. But the most common actual, long-term problem here we see was local infection. So I think that you're right, Dan. I think that applying a tourniquet, you're already in a situation where the patient has a significant injury, right? And pre-hospitally, of course, we're going to see situations where no one ever gets injured in a sterile environment, right? It's almost always they fell into a muddy puddle right after they got the injury. So this might say more like, okay, if we know that tourniquet application works, right? And I think it's fair to say that data is extant. Right.
Yeah, I think so.
If you're bleeding, you stop it. It works. Right. Then we get into the whole blood conversation. But here, I think there's an interesting argument where this might say, all right, we know that tourniquets work, but what causes the problems downstream is all this infection stuff. So maybe it opens up a bigger conversation about how we'd have to address wound care in the pre-hospital environment. And it also might be an argument for antibiotics in the pre-hospital environment. Now, and I don't mean to slippery slope this, but again, if what this study is finding is the problem isn't necessarily with tourniquet application, right? Because again, all of these patients had to survive to have these infections.
Yeah.
Right. That's kind of the big thing that this says to me, right? And yeah, this is a study that's looking at complications after a tourniquet application. Of
Uh-huh.
course, you're going to have complications after a traumatic injury. That's what happens. But in this setting, what I
Especially the high injury or high energy weapons
yeah,
injuries that we're seeing. Car bumpers are dirty. The dirt has stuff in it.
mhm,
If you get into penetrating trauma or blast injuries, rifle bullets have a shocking amount of energy
yeah.
attached to them. And those types of injuries naturally lead to big complications. Is the tourniquet directly to blame for this? I'm not so sure. And I don't think the study kind of drew that out.
No, I don't think that's what they were looking for either. And that, again, I think that that's helpful for our purposes here, right? Because the point of going over this paper isn't to say, hey, guess what? Uh, a lot of exsanguinous injuries get infections, but there's really nothing we can do about it. All right, cool, off we go. The idea with this is because we know that tourniquet application can actually reduce morbidity and mortality in the pre-hospital environment, we want to see what we can do in the field to help improve their outcomes in the hospital, which is the entire point of our existence, right? So in this setting, it might be that, okay, we apply tourniquets, and if you can, we clean the wound out before we get to the hospital, because we don't really talk about that on the EMS side, right? We say like, all right, stop the bleeding, cover the wound, off you go. And it might not be that simple. Again, this tends to lend to the conversation of, where do we draw the line between emergency medical services and mobile health, right? So in a setting where you're acting as EMS, responding to whatever type of exsanguinous injury the patient might have, and in that setting, you're EMS. But then once you get there, you're actually mobile health, because this is, say, like an extremity injury, right?
Yep.
Where someone just, they cut their arm on a piece of metal, right? So you apply that tourniquet, but the metal was dirty. So this is something where their injury was significant, but it might not have been life threatening. It was bad enough to put a tourniquet on. But now we're in this setting. All right, we've controlled the bleeding. Now what do we do?
Yeah.
Right.
I don't think this changes my practice at all. I think if I got
Mhm.
something bleeding, it's not responding to direct pressure, it's going to get a tourniquet. It's going to be 2 to 3 inches above the wound. I'm going to get it as low as possible so that I can minimize any kind of effects to the limb. High and tight, only if you're getting shot at. Remember that. People like to think every tourniquet gets a high and tight, and
Right.
that's not true. And that's not what the experts say. So keep that in mind. But this doesn't change what I'm going to do. I'm still going to put that tourniquet on. And if I get on scene and a tourniquet's already been applied, I'm going to take a look at that wound and I'm going to take a look at the bleeding status of this patient and see if I can convert that to a pressure dressing or something else that's less kind of uh, aggressive, so to speak.
Mhm.
We have it in our scope of practice where we work that we can take down a tourniquet. Um, I know it tends to freak people out when we do it, but it's generally for the better. The less ischemic time, the less time on the leg, the less chance of problems. And I think the data kind of bears that out. So I'm going to stick with what I'm doing right now, but this is interesting stuff.
And I think that's right. I don't think that this necessarily is intended to guide practice. Um, but again, I do think it kind of opens up the conversation a bit more. And maybe this is something as simple as when you go to the trauma department, you turn the patient over and you're like, listen, that wound was actually, it was in a mud pile, right? Or it was, it was in the dirt, or like there, it's visibly contaminated. And maybe that little thing, because again, keep in mind that hospitals have a lot of problems with infections, right? So this is another thing where maybe giving that report changes that outcome a little bit, where you take a little bit of time and say, listen, tourniquets on the left upper extremity, and the wound actually probably needs to be cleaned out. It had, it had dirt or, mud or whatever else stuck in it. Maybe
Or
that little
even just
conversation.
tell them what you saw when you got there.
Yeah.
They know what they're going to do, but if they know that it's dirt as opposed to concrete, as opposed
Right.
to metal, as opposed to something else, that's going to give them also an idea of what type of infection they need to be worried about. I know everybody gets broad spectrum right away, but they might culture that so that
Mhm.
down the road, now they find out, hey, this agent will work better on this. Okay, there
Right.
you go. So
And
might be
and
something
the
to do.
infection and trauma might not be tetanus. It might actually be something that's fairly significant.
There's tons of stuff
But
out there.
Exactly. And again, not necessarily practice changing, but interesting and might actually change how practice is guided over the long term. Again, this is coming from Ritblat et al. From the Academic Emergency Medicine. And for the Monday Afternoon Journal Club, I'm Ed Bauter. He's Dan Schwester. Be sure that you follow all of our stuff on Apple Podcasts and Spotify. Keep a lookout for our new website that's coming out. Follow all our stories on EMS1 and all the news stuff. And what else do we do? I think there's probably other stuff on the internet. To subscribe down below on
We're
YouTube.
everywhere.
Yeah, we're all over. We'll talk to
I
you
don't
all
even
next
know
week.
where we are. We are.
Where am I? Who am I?